blessing in disguise that I'm the last one before your lunch, the last one of the day, last one of the entire conference. So with that, I really think that we need to give a round of applause to NAMI, Montana, for putting this conference on. And that water bottle is going to be my demise, so that's just going to go away. If you have any issues hearing me, just give me a shout, let me know. Sometimes my voice goes in and out, and that's a whole other story. But here we are, and kudos to each of you for being in attendance today, making it through the end, and not only coming to support everybody that came to speak, but also each other. I think one of the biggest parts of the NAMI Montana Conference is also the connections that we make. So I also want to introduce somebody who decided the very last minute yesterday that they wanted to stand up on stage with me and be part of the presentation. So there we go. This is River. And River, this is their first time attending this conference and came with us all from Helena. And so certainly also said that they would answer any questions should anybody have them, but if otherwise, just going to be up here with me. All right, so there was also a couple of little tiny discrepancies, but I don't think it'll affect anybody too much on the program. So I'm going to talk about some residential group homes and homelessness and that kind of stuff. While that's a component of what I'm talking about, I'm actually going to talk about perceptions of effectiveness within community mental health residential program. So a little piece about this was my dissertation research. So Matt has loved calling me Dr. Preble, but I'm Jen, right? So I'm Jen for many years, and so this was the work that elevated that title, that many years of education and years of experience. So I'm going to kind of share bits and pieces of that and who I am and where I come from. So with that, thank you, Tim. So who am I? I am a suicide prevention advocate. I go to Washington, D.C. I have experience with the American Foundation for Suicide Prevention. During the day, I'm a therapist. So we'll talk a little bit about what that looks like. I'm also a supervisor. I've been in many roles in many different programs in the community mental health world. I am also an individual with an indivisible disability, and so some of that shows with the doc that's right here. I also am a professional, right? I do presentations such as these. I stand up at legislative committee hearings. I really make advocacy at the forefront of the work that I do. I'm here to serve all of you, whether you're a colleague, whether you're a client, a customer, my friend, my family member. That's really what I stand here for today. So with that framing, something else I want to share is perception. So this is Wacky Wednesday. This is one day that we had as my daily job that we dressed up with wacky clothes. And after this, what I was told by River is that this is what I look like every day as a therapist. Yeah. So I wear that proud. What also happened that day is that I ended up going to court unexpectedly. So I stand in front of judge's courtroom and I end up giving all of these opinions about mental health and progress reports of individuals that are there and intersecting with our system. And this is what I'm wearing. So can you imagine perception as the ability to see, hear, become aware of something through the senses? Because I think what you've heard in the last 2 days is a lot about different metrics, we heard about a randomized control study, we heard about efficacy, we heard about a new model of effectiveness and sustainability. And so I'm going to take just a different lens and talk about what do people perceive as effective. And this is a tiny study, right? It's in a very small area of our state, and it was a starting point. Because what we also learned through our history, if you don't mind, Tim, I'll get to this guy in a minute, is that there really isn't a lot of studies about the effectiveness. So where is Waldo? There's some Halloween baskets. Where's Waldo is in these slides. So in the next few slides, when you see Waldo, shout out, tell me that you're paying attention, and you can win a little bucket for the fall and winter seasons, just because I like people interrupting me to get me off of my own nerves and anxiety. So with that, let's talk about the history of where we stood today and what made me decide to do this research. Maybe.
At the top of research.
There you go. Who's the first one?
Kids.
There you go. Go ahead and invest. So we're going to go over the brief history. This study that I did, we called it the red tape study. So there's 3 different areas that the study kind of evolved through. And then we're going to spend a lot of time talking about red tape, partly because that's what I had to do to graduate. And so that's the most prepared. But also because I think it's really informative for this conference and everything that NAMI stands for. And then we're going to end on kind of the next steps, very similar to the CCBHC model, and some of the things that you can each take away and do today. So mental illness costs us billions of dollars every year. That doesn't include, like, we just talked about primary care, we talk about homelessness, we talk about the criminal justice system, we talk about community mental health centers, all of the branches of those centers and what we offer from MAC teams, PAC teams, residential programs, peer support services, all of that other stuff. It costs a lot of money within the US for us to continue treating these severe schizophrenia and related disorders. So again, we're talking a very small population in comparison to costing a really large amount of money. So you would think that we would have a lot of good evidence and research that tells us what do we do that's really effective for not only reducing the cost, but improving the outcomes. So 24.7% of 50 million US people can't access services. So just think about that. Not only do we have a really high amount of dollars being spent and services that need to be offered, but 50% of them can't even access the services. As in all research, you have to do a literature review. We're not going to spend too much time in this, but the things that I want to point out is that a lot of the research that is current and is being done is out of Australia. So there are similar programs to what we operate are called continuum quality, or CCUs, community quality, well, there it is, something CCUs. And so they took some populations, different subsets of populations, and interviewed also for perceptions of effectiveness, very qualitative design. And I was able to pull that into the state and see where could we use that research and where could we not. Otherwise, when we did deinstitutionalization in the 1960s, there was quite a bit of research as to if we move people into their communities and they have greater access to their friends, their family, the support systems, is that a better quality of life versus living in these, asylums and these Montana state hospitals, etc. So there was some research about that. Yes, all of that is good. People report that they would rather be in the community versus being in these hospitals. But then it fell off, and there's no more research. And so this was really bothersome to me, and that's how I kind of landed with this project, is how do we know what we do works? Besides that people want to be in the community, and it costs a lot more money to be in the state hospital, how do we know what we do works? Montana, guess what, we're all from Montana. Most of us probably know this, but in case you're new to Montana, we have 700 driving miles from one point to the other point, just in the state. We have one state hospital. We talked about 50% of people don't have adequate access to care. This is one of the reasons. Only 1.07 million people. So in another talk, I was doing some criminal justice system work, and we talked about in Florida, and there was more people in that county than there are in our entire state. So when you want to access services and provide more resources, some of it is just a capacity issue. Well, what are we known for? We're also known for high suicides, high DUIs, service members, veterans, and their families, and our American Indian populations. We have 7 reservations in this state. So there's a lot to be said about the types and the quality of services that we need to run.
Waldo Center.
Yay! One of the theories that I developed.
It's our company. It's gonna look like we got a cheap victim.
Yeah, everybody else has to pay attention. We all, when you do research, you have to have a model or a theory that you're building your research off of. And so what our state and what our community mental health centers believe in and operate and provide services is called recovery-oriented care. This was a SAMHSA-driven model. 2010, 2013, they did some updates. This is what we're supposed to provide. In case you didn't know and you're working with individuals with mental illness, you want to provide hope. You want to recover pathways to services. You want to provide, everything from person-driven, client-centered care in any capacity, whether you build that in your treatment plans, whether you do that in your individual context, out in the community, case management, peer support. This is really where the forefront of your brain should be. It should be listening to those that we're serving and identifying what they want to work on versus us dictating their treatment for them. So this was the premise that I not only built the questions that I interviewed for, but also just in the belief system of the services that we are supposed to be providing, and wondering, really curious, leaning into that a little bit, do the people that participate in the study, are they going to identify that we do these things? So small sample size, right? We're in Montana. This was one community mental health center that I had the blessing of getting permission not only from the institutional review board, but also the agency to be able to do this study. We picked a sample size of 13. Okay, so this was 5 clients, consumers, residents. It was 5 employees, and it was 3 other participants. And those other participants included, your front desk administration, it included administrative within your C-suite, it included, other team members within other programs that don't intimately work in the program every day. And some of that was percentages. So it was percentage based off of who we were serving at the time. There was a lot of other metrics that they had to qualify for in order to participate, including that you had to be within the residential program if you were a client for a minimum of 30 days. You didn't have to currently be in the program, but you had to have had a length of stay of 30 days within the last 3 years. You had to have some familiarity with the program if you were employed by it, but you didn't have to be the most senior person either. You could be somebody that had just started, but you got through all of your minimum your minimum trainings, your RANT, your CPI, fire extinguisher training, all of those ones that are required. So there were some qualifications, but otherwise the study wasn't about the demographics. It wasn't about necessarily what condition you had. It wasn't about how long have you had that mental illness, how many hospitalizations. That's not what it was about. It was about getting a feel for what you perceived were effective services, no matter where you intersected. So data analysis. So we heard yesterday randomized control study. We also heard just a little bit ago this morning about another similar study project. And so some of the ways in which we build good quality data from collections, and side note, it is really hard to get an institutional review board to authorize studying people with severe disabling mental illness. Anybody know why? Confidentiality?
Vulnerable population.
Vulnerable population. That's it. Ding, ding, ding. That's the winner. So in the eyes of people that don't work in this field every day, it's hard to convey this perspective that, yes, we work with a very vulnerable population. However, they have the rights to consent to the study. They can say yes or no. And it was also equally challenging because I'm very familiar with the population that I work with. And so then there was these questions, is there going to be bias? Am I going to have influence as to whether that changes their length of stay, as to what services they're provided, as to whether the employees, if I can do disciplinary action if they don't participate in the study. So let me tell you, there was lots of conversation and lots of appealing of the ability to do this study. And I share that because one of the takeaways that we'll get to at the very end is how do we continue to evolve this study and elevate the conversation and get more voice from those of you that are working in the streets every day. So these are just big fancy words. of the different layers of qualitative design. So when I'm doing interpretation, it wasn't like we just did the interview, we had some audio recordings, I had some transcription, I had some different other things. It was, no, I had to do each one of these. I had to go through all 13 transcripts. I had to do each type of coding. So structural coding, for example, is you have all of the questions per participant. And what you do is you flip that around and you take all of the participant answers and dump them into each question. So what that does is then it allows you to do some of those other, what they call secondary and tertiary coding, where you start looking for keywords and key themes. And so what this does is it takes my voice out of it and makes it all of yours who participated in the study. And trust me, there's some of you that participated that are here in the room right now, which just excites me. Because this will also be some of the first time for people that have heard the results of this study. And then there's a requirement of the things that I have to do as the researcher. So randomized control studies that are very quantitative, and they talked about it removes all bias. Well, there's a lot of bias that I have in this. And so these are things to complement, but also bring to awareness that it's okay to have that bias. And this is how it helps inform the study. Okay, now we're getting to the good stuff. Can't see that, it's really funny. I'm getting to the good stuff. Which gas do I want? And because gas is so expensive right now, we need ultra mega octane yeast. There's Waldo who said it first. Over there. You guys are doing good, you're catching on. This is better than true false. If Mary was still here, she would appreciate that. So this is the really big picture findings. So I ask all these questions, I do all this data interpretation. The really big theme over here is moving from isolation to socialization. So what does that mean? Well, participants really spoke about the effectiveness of the program is not about all of the individual metrics that we have to measure, partly for administrative, partly for financial, partly for whatever other reason. But what's really important to everybody is that individuals, like those of you that are here today, this is a social opportunity to gain skills to help us succeed and practice a recovery-oriented care. So within that, there were 3 tenets. One of that is support, and that's emotional and physical, and I'll touch on that in a minute. One of them that actually really surprised me is place. And we took attention to the terminology of place versus home or house. We heard yesterday from Kath about houselessness or homelessness. Well, for many of the individuals that are experiencing the system, why we call it a residential group home or an adult foster care home might be another terminology within the residential program. To the folks that are living here, it's a place. They're not spending all of their entire life here. It's just a place that they go to. The same as a state hospital, the same as a homeless shelter, the same as an apartment. There really isn't that onus to this is my home. So within that, we talked about the quantity and the quality, as well as the type of environment that they were living in, because some of them were not as good as others. So this last one that became the red tape study is stability. And so within stability, there's flexibility, freedom, and autonomy. And so after just a couple of introductory slides, I'm going to get into that in more detail. So support. That was one of the key themes within that. Participants shared about freedom, healthy environment, transportation, services, facility, and that support is like a medicine. And I found that was really kind of a really cool adjective to describe that it's equally important to have support as it is your psychiatric medication. You can't have one without the other, and that is provided within a residential program. As well as, and again, I could probably talk for days about some of these other nuances, but there was a lot of voice about freedom and that they have the freedom to come and go. And even from staff perspective, it's like, we're not babysitting you. We have a sign-out sheet. We need to know. You need to be accountable. But you have that freedom where when individuals compared those levels of care, whether it was from a state hospital or a corrections facility, it was noted, you don't have that freedom. So again, I'm not going to get too much into this one or the next one, but so place, I kind of alluded to this a little bit. So it was about the type of place, the quantity of moves. So remember, every time somebody goes to the state hospital, that's a move, that's a number to them. Or whether they go to your local hospital, again, that's a number. It doesn't become like, I was here for just a short amount of time. It kind of is this revolving door where a lot of people that are in our residential program have moved 5 or more times in and out of that type of program. Stability before red tape. So this is our red tape study, right? So we really looked at what is the administrative, lack of a better word, bureaucracy that is preventing us from making effective programs. Or what is the administrative support that is helping these programs be effective, and really how do we know that? And who is watching, and why do we have staffing ratios at what they are, and why do we have, part of this, without getting into the weeds and recognizing that I have my fellow Department of Public Health and Human Services team here. This is, again, my participants' information. This isn't me or my agency, but it was like, why do we decide that you get 60 days versus 3 years to put somebody through a residential program? What does that mean, and how do we determine that, and where's the research that provides it? How do we do these recovery-oriented care, and is it individualized? So remember, this whole study was based off of the model of recovery-oriented care. So are we actually doing that? And so the participants shared with us, and that's what I'll share in a minute. Community systems. This is another one where it's like, okay, so the residential program is on a continuum, and how do the other community systems fit within that? And are we partnering, are we working well together for them? Okay, bear with me, I'm gonna try and read this from the side. It has to come down to flexibility. I really think it has to come down to flexibility both within the particular program based on what's available in the community, but also more statewide. A flexibility of funding for different kinds of things, because there just simply is never going to be a one-size-fits-all. What as a program, what works well for us in Helena with the personality of the staff and or the resources we have available because of the size of town or because it's the capital city, they're just simply not available in, say, Miles City. Even Butte has some challenges just because of their financial situation in the state. Just being able to have the state willing to respond to different kinds of programming, I hate to use the word pilot, but pilot programs, because once it becomes not a pilot, then it becomes one of those rigid types of programming again. So it's both good and bad. We just heard about the CCBHC model and the hope that we have within that will allow for some of these things to be considered, right? So right now is a really exciting time in mental health because our participants, our study participants are identifying that we need more flexibility and autonomy within programs, within just one program. We're not talking about the whole continuum, but we're also seeing an evidence-based model from national that has been in the works for years that is just coming to Montana, and we're gonna implement that. Like, Montana is going to do that. And it will allow for some of these things, recognizing the disparities across the state. So another component of that red tape was training. All right, I don't know how many of you work in mental health, but we know the provider rates are low. We know that sometimes we don't get the best of employees and we want more, but we also have a training issue. So how do we get and know the type of training that's required? Is it just evidence-based practices for those that hold a master's degree and above and all of the letters after their name like myself? Or is there other training that's available for other folks that are providing the day-to-day skills and going out into those communities? And how do we identify that and how do we make it available? Because what our study participants were saying is that it's not the right training and there's not enough time to do the training. We have a set requirement that has to be provided within 30 days of an employee being onboarded. And I can tell you many of the participants also shared from a staff perspective that they don't either get it in time or it's not enough. And they feel like we're throwing them to the wolves if they've never worked a day in mental health. And how do we do that? Well, another participant said that there needs to be more training, interpersonal training. Well, how do we do that? Well, they go on to say how to essentially interact properly with clients, boundary setting. It would be hard to pass the training on, because sometimes you're always struggling to have the staff at the homes. So when there's mandatory training, whether that's monthly or otherwise, what participants are saying is, well, we can't staff the group homes if the staff are always in training. We can't have good employees if they're not receiving the training. And another client participant shared, like, can you just post the training so I know when the staff are getting trained and what they're getting trained in, so that I have some understanding that they're continuing their education? Well, how cool is that? So believe it or not, people that live in our homes actually are really engaged, and they want to know, and they want to be a part of that. And why shouldn't they be? So there were some things that were really easy and we can implement today when we go back to our homes and our offices and our buildings, as well as there's some of these things that are going to take a little bit more time and advocacy at even a policy level. Expansion. Well, guess what? 50% of our people don't have access to services. So what's one thing you might expect? Well, people want services to be expanded. They want services in our rural areas. They want services offered in a multifaceted level, but we also need brick and mortar buildings. We need more group homes. We need more crisis facilities. We need more in different areas of the state, because it's not good quality care to have one state hospital that's the only one and it's that far away. And we heard about the number of hours that it takes for our law enforcement or whoever to transport to some of these facilities. I used to work in Eastern Montana, so I can say that with my own experience, that it's easier to transport somebody out of state than it is within our own state to receive that home quality care. You know, another thing is just more beds. Well, this is really interesting, because how do you provide more beds within a group home? I was part of a project that we were able to build a 12-bed group home. Standardly, we have 8-bed group homes. And I'll tell you, I don't know if I would do a 12-bed group home again. It's great, and it's great because we have that many beds and we have a really great layout and all of these things. But once you move into another 4 beds, wow, the dynamics really change in your group home. And the milieu setting for clinical words, and even some of the clients have now told us it's too noisy, it's this, it's that, we don't have enough safe space. Like, there's a lot of things that have come with that. But again, it's a place, it's not a home, it's become a place. So a participant said what we have is not sufficient. It feels like we have a Band-Aid model and it doesn't matter what our program is. I think there, at the time it was Center for Mental Health, now Many Rivers, probably doing the best they can with the resources they have. The problem that a lot of mental health organizations have right now, where they're underfunded and they're understaffed. Boy, didn't we hear this several times in the last 2 days. And so this is really recent research. Just for perspective, this was conducted earlier this year in 2020. So you're seeing all of this really enriching information come from multiple different avenues and languages. So we know that we're supposed to be providing recovery-oriented care. What did the participants really say are being promoted? Well, one of them said the medical model or reparenting models or whatever models we've been through. So to provide perspective to that, there's been a lot of different models that are thrown at us. And again, remember, like, where and why do we make these decisions? Is it really based off of a needs assessment? Is it really based off of research that's conducted in other states? Where is it based off of? And often we find that it's not, it's just a growing trend. Well, one state's doing it, so maybe we should do it, or another agency's doing it, so maybe we should do it. So that's what that reference is about. And so they don't work because residents don't develop internal boundaries. The way the recovery model does, a lot of clients will do as well, as long as they have external boundaries on them all the time. But that's the point, it's gotta be internalized. So I think the recovery model does that much more effectively. And so the idea is to get, clients functioning in the community responsibly and as independent as possible. They've got to be able to internalize boundaries and habits. And I found that really speaks to that recovery-based model, because again, we're teaching and finding tools to internalize their own recovery and provide multiple tenants. Are they leaving the program with hope and the ability to access groceries and public transportation? and find resources and create friendships and create that network of supportive people when they leave a residential program. And arguably, some of the participants definitely said that the program is doing that, but whether the larger model in theory is, that remains to be determined. So also in recovery oriented, it's just a really interesting kind of caveat to this whole thing is through the research, administrative guidelines are changing. And for those of you that don't live in the residential world, there's been lots of changes in the last few years, and it also coincided with COVID and also coincided with funding cuts and all of these things. So when you look at the research part of it and a control factor, is that really able to pull out? No, not really. But people were talking about it. So it was their perception that we were running into a lot of red tape about now we have, I don't want to say an undetermined amount of time, but we did, because it was based off of their individual pace, their recovery, their treatment plan, those SMART goals. And so people could stay in the group home for a few days, a few weeks, months, and even a couple of years and move through the different levels of care. Well, through this, there was also an administrative change that we're going to have these different models and different tiers of care. Part of that is financially motivated, but it was saying, okay, so now you have 60 days, you have 60 days for rehabilitation. So take somebody from Montana State Hospital or behavioral health units or wherever, and you get 60 days to rehabilitate them and move them to another level of care. Well, again, like, what is that based off of? Is that based off of research? Is that based off of their blood pressure levels and their cholesterol levels and their tobacco sensation? Where is that information based off of? Well, then you can also have another 60 days. You can do a continued stay because we moved to managed care through all of this as well. So you can advocate for a higher length of stay. But at some point, you have to, within that 120 days, move them into a different type of model. Well, what's the significance of that? Well, that different type of model doesn't have the same wraparound care. It's not as high for the acuity. And quite honestly, it can take 60 days just to get a birth certificate. Well, did you know you can't get a birth certificate? If you don't have that, you can't get a picture ID without that. You can't get your prescriptions without that. You can't get access to services. So within that 60 days, those basic fundamental needs and that, like, your right as a person living in our communities in a state, like, you should be able to get all of that. But it can't happen overnight. And so, again, just pushing against that just a little bit about where do these regulations come from? The participants, I mean, it doesn't make any sense. So that was, I feel like, really important to note because it doesn't fit recovery-oriented care. It doesn't fit those tenets. Okay, so person-driven. Are our policies and our regulations person-driven or are they administratively driven? Do you have many pathways to access your care? If you want to move out, can you do so? How is your wraparound team supporting you? Do you have services in different areas of your community, or do you just have services within one? And is it meeting all of your needs? And I won't go into all of these, but people talked about respect, especially the participants receiving the services. They're able to identify when an employee respects them or not, whether that's verbally, non-verbally, whether that's just their intuition or their guts, or no matter what that is. And they didn't hesitate to let me know. So I think, again, are we operating in a recovery-oriented care model, and what do we have, as even at a program level, what control do the survey participants feel they have versus even administratively, and then versus policy level-wise, and then even high administrative within all of that. And so that was really enriching conversation with that. So community systems. River might want to jump in now, but talking about you're in one program and you're going to move in between a lot of different programs within your own agency that you're receiving the services, but you're also working within community organizations in a lot of different sectors. You're working with criminal justice services, you're working with your hospitals, You're working with maybe other mental health facilities because maybe they're receiving, a therapy or case management or, somewhere else. But you're also working within states, you're working within legislative sessions. And so that community system, I felt like one of the participants nailed it when they said, I think there's something that some things people at hospitals can work on with people who struggle with mental health, especially when they come into the ER and ask for help. There's a lot of nurses or people that work there that will just give you an attitude if you're not there or if you are there for mental health. And sometimes you're wasting a bed, you're stupid and stuff like that, and it should be to maintain stability with mental health. This isn't talking about a specific hospital or the issues within it, it's just talking about the continuum of care. And we have learned throughout the last 2 days that we need to be doing better caring contacts, we need to follow up with people when they discharge from the hospitals, we need to have empathy within whatever system you're in, whether that's a residential, whether that's your outpatient, whether that's your trauma-informed care at the front desk that you walk in and receive services. And if you're an advocate going to a grocery store with one of your friends, your peers, your colleagues, your customers, your clients, then keep this in mind, that we all pick up on this. And man, oh man, would it be great to have an entire community and an entire NAMI family where everybody could say the next time that somebody's doing a study that this has improved quite a bit. The people are learning how to do these things. That's my hope. So structure flexibility, this is, I think, the last tenet of all of these within red tape. People say the program has the right to come up with the things they think they need to be fixed. Again, we have requirements that we must follow. Who decides those? Which offices do they sit in? There's a lot of different examples. Maybe that's a conversation for lunchtime. But we have to recognize there has to be some flexibility. There has to be needs assessment. There has to be information that informs why a program in Helena would look different than one in Atlantic City or Glasgow or up here in Kalispell or Butte or wherever. And what things have to be the same. Like we heard within that CCBHC model, you have to provide these 9 core services. And the rest of it, you kind of get that freedom and flexibility based off your location, your population, what access do you have, how many providers do you have. Are you looking at a 20% vacancy? Well, where can those positions be vacant and where do you must fill those positions to ensure the quality of care? The bottom line is that our program is, yes, they're looking at clinical criteria because that's important for the state, but the red tape, the bureaucracy, and I've seen it with formal application processes to a residential program, takes a lot of time. So there was a participant that shared, they worked at a couple of different agencies, and this was complemented by a client participant that, in one location of the state, they might not ever get index services until they get that ID and they can complete an application. Well, by then you're looking at days or weeks or even months before you can get into the right level of care that you need to stabilize your symptoms. Where some programs, okay, you need to pay your rent, you need all of these things, well, you're gonna get into the program today, and we're gonna work on those with case management until you can get those. And yeah, we know you don't have Social Security on because that gets turned off when you're in the jail or that gets turned off when you're at the state hospital. And so you really don't have any income to pay the rent, but we're gonna work with you so that you can still access the services and access the care that you need. And that's really where these kind of comments are coming from, is that participants know that and participants appreciate that, and it's different in different locations. You can drive 150 miles and find out that, well, actually, there's a 6-month waiting list and, you're not high enough, so you can't really get into services, and, well, you're already here, well, the best that I can do is request for records, and then maybe you can get in to see a doctor, but actually, probably not. There's probably another 6-month waiting list. And, oh, well, you're homeless, well, I can offer you the homeless shelter, but maybe you should probably go back to where you came from or whatever those things. So participants were expressing that. And so how do we take these ideas and these concepts and move them into a measurable fashion that then we can use that data to inform those outcomes? That's really what all of this is about. Documentation needs to be simpler. In respect to continuous stay, prior authorization, the paperwork becomes a time burden. I wish some of those restrictions weren't in place because it would be easier to serve people. This would mean our staff would have more time to engage with clients, do groups like cooking, budgeting, games. When things are triggered for those same clients, how do we handle that with more client engagement? So you're hearing at the same time that funding mechanisms changed and administration changed, and we had now third-party managed care. Well, your staff, that you're already short-staffed, are having to choose now between client de-escalation and getting that paperwork done so they can remain in your program. And so it was really tenuous, and so I think part of that is the timing of what was voiced in the survey and the participant study. But I think it's really good information. I think it's really important that we hear that people notice and people are having to choose. And where does that leave us?
Well, Nikki, go first.
Yay! All right. So just kind of wrapping this all up, I'm not going to get into the weeds about the research itself, but the literature review basically demonstrated a lack of research. Not only qualitative studies, quantitative studies, any studies. I had to exclude anything that was related to your intellectual disabilities or your youth services. There's actually quite a bit on residential programming for our youth, but it fits a different population, not only in age, but also ability to consent. So all of those studies weren't considered. Your current operation versus the participant desires, we see there's a conflict, right? We're operating and we're doing the best we can, meeting all of the needs. And there was only 3 study groups. Originally, this was going to be much bigger, and I wanted to hear from our financial team, what do they feel is an effective program? Is it as simple as your beds being filled, or are there more things being considered? I wanted to hear from your community, whether it was criminal justice services, whether it was friends and families, wherever you fit. I wanted to hear, what do you feel is an effective program? Because you don't see the nuances every day. You don't see what's being operated. So I think that there's a lot more room for research that I'll mention again. Strengths and limitations, as with all research, there's some strengths, there's some limitations. So it was a really good quality design. The evidence is really strong for the population that was interviewed at that time. Much like anything that's on print, it's outdated almost right after it's printed. So in the world of research, this isn't outdated quite that fast. And there's a lot of room and opportunity to build on it. There's a lot of fancy publications and different things that I'm supposed to do. We'll see if I get there. But it's very limited. So ethics of it all, again, I mentioned at the beginning, there was a lot that I had to go through just to be able to do the research. And I think that there's just a lot to be said about that, especially as we grow our peer support network and we grow voices and we help people be able to advocate for themselves, because the interviews range from 13 minutes to an hour and a half, right? So again, it just shows how much people have to say and how comfortable people are with saying it. Some people not at all, and some people could probably talk to me for much longer if I hadn't cut it off. There's a direct practice application, policy changes, and future research, so I want to explain those a little bit more. So as I said, I was able to, once this was finished and ready to go through my committee board and get everything approved, there was changes that we could implement immediately. There were conversations that were happening so that we could impact those immediately. There were, whether that was training or whether that was some metrics that we could look at, whether that was presentations, lunch and learns, whatever. There was direct practice application. Policy changes, we know there's policy changes that can happen, and some of it is embedded within policies that are already being presented throughout the summer at interim committee hearings. I was there, and I would encourage anybody else that wants to go there with me, please do. It's terrifying. I'm still nervous as I'll get out every time I do it, even though I've done it. It's still terrifying. But those pieces are really important, and those stories are important to share, because that's really what matters. And I will tell you, and there's some folks within our legislature that's here right now that will tell you those personal stories matter. Yes, it matters when our Behavioral Health Alliance shows up and has this data and this really good stuff because that's information that's based off of real time. But it also matters with stories and how you're receiving the research and the services and those changes that need to be done. That's important stuff. Voice your opinion not only at the legislature, but within the services you receive. So there's people all over the state right now that I just really want to empower you to go back and tell your therapist, tell your peer supports, tell your management, tell whoever, this is what really works for me, and this is what doesn't work for me. Now, can everybody make the changes that all of us want all the time? No. And you need to go in with both eyes open for that because you can't. And some of it is really tied in multi-layers that even I don't know about. But man, I would love if we could really elevate the voice within mental health altogether so that we can complement all of the work that's already being done. But right now it's kind of in silos and not everybody really knows about it. So let's pledge to leave here knowing that your voice matters and that you can continue to do this work. Future research, if anybody wants me to do more research so that we can get those numbers and those sample sizes up, and you're at other agencies or you want to participate because you've been a participant in residential services around the state, let's do that. That's going to take a lot more time because now I don't have time to do that, but I'm committed. And I'm not committed to writing a book. I'm committed to doing journal publications. But I think that this is really important, and it's important for the entire U.S. When I say there's limited research, it's not just in Montana, it's in the entire U.S. That there's really no research about program effectiveness within your residential programs. And I'm sure that's true within your MACT programs and your outpatient therapies and your ACT teams. Although those programs seem to have a lot more voice right now because there's already a set of standards that was developed, and we already have evidence-based practices or evidence-informed practices within your outpatient sector. We already know, some of the time frames within traditional services in terms of do you get 6 sessions, you get 24 sessions. We already know kind of where those align with different mental health diagnoses and conditions. So that was a super, super fast presentation about a lot of research that I did, but what questions or comments do you have? Yeah.
What happens when
Tim, you can go to the next slide.
when you're into psychiatric care without
Sorry, I wanted people to see the Waldo before I lost track of your question. So yes, what happens in terms of psychiatric care? You get to decide who got that first. I have no idea.
when you're institutionalized, they have to take it out of your Social Security. What happens when you reapply and they tell you that they drain the swamp?
Okay, so I'm going to try to repeat that, and I'm not sure I got all of it, but what happens when you're institutionalized, you lose your security, and then what?
You lose your rights for Social Security due to the fact that you're mentally ill. Through other agencies for life insurance.
Oh my gosh, I have no idea. I haven't even considered the life insurance component of it, and that you lose coverage based off of Social Security qualifications, and yeah, I have no idea. Sorry, it's not a very good answer.
Hello. Do you know of any research going on or from your peers from when you're in college or anything that is specifically for so something that I see, I've been in this field my entire adult life, is that many of our clients don't have a good relationship with their families. Is there any research going on right now where we can maybe look ahead to fixing those broken families with, generational traumas and looking at that aspect and component of mental illness. I'm constantly very aware of if I become unstable with my medications and I lash out on my kids and become verbally or physically abusive to my kids, or I become addicted to drugs or something. Those are generational traumas that are just going to continuously link with my kids, and then it's just going to be passed down the line. So is there research going on right now that is addressing that component that you know of?
Yeah, so if I can rephrase that question just for online viewers, is there any research about generational trauma associated with kind of this mental health and family impact in terms of, if you experience mental illness and then lash out to your kids, is there research available about that? Did I get that right? And because that wasn't something that was considered in this study, I wouldn't even want to guess if there is or isn't. Certainly, we could all look it up, but I have not looked.
Next research topic.
No next research.
Jennifer, is there any place that you know of that gets it right? Is there a state? Is there a county? Is there any place that you've looked at or that you're aware of from others that, by gosh, if we could only do what XYZ is doing?
So the question is, am I aware of anything or anywhere or any program that gets it right? They're doing X, Y, and Z and it's right. So part of the difficulty in answering that, I think, is because of the complexity and what are we trying to define as right? So that was really what this is about, right? It's the perception that right is if you rehabilitate somebody in 120 days, or is it right if they lower their blood pressure scores, or is it right if we have X number individuals that have tobacco cessation? Like, what is right? And so I think that would be a fool of me to try to answer because I don't know what's right.
But even if you went back to that basic question, half of the individuals who have a mental health and or co-occurring disorder do not have access to services or are not receiving services. Is there any state that you know that is in the lead of really addressing individuals that are not receiving any services?
No, so there's a couple of reports that come out annually. I know Mental Health of America does one. I know one of them that I cited was specific from the government on schizophrenia and related disorders, and it ranks states for who's accessing care better or has more funding or certain models of care. And so I think, from state views, you could look up from that avenue, but does that mean that everybody here in this room would agree with that report? I don't know. But I think you could look at creating, that was my original goal with this, is creating some sort of an evaluative tool that would say if you're doing these things right, you're more right, and less wrong, if that makes sense.
Thank you.
Yeah, sorry.
Last question.
Go ahead.
I was wondering if your helper had anything to add.
You're wondering if my helper has anything to add? That's a great question. They say they don't know. Thank you all. Thank you, Matt. Thank you, Nami.